Welcome to another CEO Wisdom Pod. We have Ahmad Saleh with us. He's an MD, MPH. He's a doctor, co-founder and CEO at MakeDeathsCount, and a Cornell, Yale, Gates scholar. And I have an interesting conversation about debt. Precisely, Make Deaths Count, aka
Mhm.
MDC. Um, it's an organization that aims to increase mortality surveillance in low and middle income countries. So that's a very fascinating topic. Podfire.com is presenting this podcast. It's my podcasting company. If you want to start, scale, be invited to podcast, you can go to podfire.com. Ahmed, welcome to the pod. Tell me a bit more about yourself and what you're up to nowadays.
Yeah, thank you so much, Charles. Appreciate the invite. So as you said, my name is Ahmad. I'm the CEO, co-founder of MakeDeathsCount. So I'm a physician currently in New York City. I actually did my master's of public health while I was in medical school, given the fact that, during my training in Brooklyn in New York, I worked a lot with underserved communities, and I really saw the need to kind of supplement my own education with public health. And really, it wasn't until I was doing my master's in public health at Yale that I came sort of with the realization of sort of really one of the biggest issues in global health that is often not really talked about, which is the lack of registration for deaths. So, simply put, according to the World Health Organization, half of all the deaths in the world are unregistered, meaning people are dying in their homes, in their communities, and they never see a doctor that actually says, you died of this or that. And this is not even to speak of the fact that, even when they do go see a doctor, they may not provide the most accurate actual causes of death. Sometimes they say, oh, it's a heart attack. Oh, their lungs stopped working, but there's a lot more detail that is needed. And so, kind of with that information, my world, we deal in data. It's important. Everything that we do is because we have the numbers and know where the issues are. Coupled with the backdrop of COVID and the pandemic, it became even more stark the fact that we need to address this issue in some way. And so, for me, coming from this world of really academia, this issue has always been addressed from a research perspective. How can we do research? How can we raise funding for it? But personally, I saw that it was far too bureaucratic to actually implement real change the way that at least I wanted to see it. And so I really wanted to go down the social entrepreneurship route. I wanted to see how can we address this from really a business mindset, if possible. And so during my year at Yale, what I ended up doing was really pulling together from the different resources, my professors and mentors, to start essentially Make Deaths Count, the first and only nonprofit organization in the world that precisely, as you correctly mentioned, provides this service to NGOs and ministries of health. So we're essentially an organization that provides consultation service to NGOs as well as ministries of health, primarily within low and middle income countries. So that 50% number that I said, that was globally, but it's actually up to 90% in low and middle income countries. So think about Latin America, Sub-Saharan Africa, Southeast Asia. A lot of these regions have areas where there's almost no certification of the debts there. And so that's kind of how we started during that year with my co-founder. And we've been going strong for almost 2 years now. Happy to go into kind of what we've been doing so far with that.
Well, dude, it's just fascinating, but tell me a bit more about yourself. Like, first, how did you
Sure,
get into medicine and paying for all of these PhDs and medicine studies? That's
sure.
quite hefty. Like, how did you get the funds for that?
Absolutely. Thank you. So a bit of a background. I'm a son of immigrants. I was born and raised in New Jersey in the US, and my parents immigrated from Egypt. And growing up, I got to see a lot of sort of their obstacles with dealing and navigating the US healthcare system, primarily with obtaining medications or insurance and all of that. So from a young age, I got kind of a peek into that world, and there was an incident as well where my dad needed to get a procedure done. He works a lot on his feet, and he really needed it. And it got to the point where we couldn't get it in the U.S. and he had to fly back to Egypt. He was able to get it because it was financially feasible, but unfortunately, he dealt with some complications from it. Thankfully, it worked out in the end. But me being a 10-year-old, all I saw was like my father, who was very active every day, wasn't so for some period. And so that really sparked my interest to go into medicine. I wanted to kind of be on the other side of the door that they were knocking on, and be able to take part in those decisions. And so I, grew up in New Jersey. Where I grew up, if people know where Elizabeth is, it's quite an underserved area. A lot of people don't usually go to college. It's not the path. But thankfully, I knew I had no funds to afford any of these degrees that I wanted to get. I was able to apply and get the Gates Millennium Scholarship, which is essentially a full ride to any university of your choice for graduating high school seniors in the US. And then I went to Cornell. I studied Bachelor's of Science, where I was keen on going into medical school. And then after graduation, I went to SUNY Downstate for my medical degree. Took a year off to complete my master's in public health, as I stated at Yale, then came back and currently practicing in New York.
And how hard was it to get into these top schools?
I thankfully I was very deluded with how hard it was. I just applied. I was like, yeah, what's the big deal? And thankfully they saw something in me to be able to get me in. But as I went through the process of applying to these different universities, I kind of really worked on understanding my own motivations for every sort of milestone, why I wanted to go to med school, why I wanted to do my public health degree. And thankfully they saw that it was a compelling narrative that allowed me to do it. And even more so for me, coming from a world where my parents haven't gone through the college system, I really don't have people that I know who can tell me like, oh yeah, you need to do this and that. I was sort of relied heavily on people around me, my guidance counselors, YouTube, podcasts. The internet is a fantastic resource. Different resources at college when I knew it was like, look, I want to do this. What are the things that I don't know how to do? What are the questions that I'm not asking? Because people are like, sometimes I remember, and you know, it's very surprising to me, but I didn't realize that I needed to like submit the SAT when I needed to submit it for college. I was like, oh, I'll just do it after I apply. They're like, that's not a thing. You need to like take the SAT in order to get into the school. So there was some sort of near misses, I would say, but thankfully I relied heavily on people around me to be able to guide me.
And then you
Yeah.
got the certification. And what was the conversation with your parents? Like, hey, dad, finally, I'm not going to be a doctor. I'm going to go into this social startup.
Yeah, so funny enough, I'm actually still doing both.
Okay.
I'm
Wow.
yeah, yeah. I think for me, that's what I want to do. Like ultimately, career-wise, I still want to have my impact in global health, both in the clinical realm as a physician, as well as a social entrepreneur, kind of impacting systems and creating sort of more population level change as well. So for me, it's been my ethos. How do I impact my patients and health overall on the individual level as a clinician, but also on the population level through the work that I'm doing.
Then how did you first get that Gates Millennium Scholar thing? You're an
Yeah,
ambassador of that now.
sure. Yeah. So actually, when I was a freshman in high school, my English teacher was kind of she took a couple minutes out of class one day, and she was telling us how proud she was of one of the then graduating high school seniors who got the scholarship because it's such a competitive scholarship. She wrote the letter of recommendation for that student, and it was at that time only one out of two people in all of New Jersey got it. And I kind of remembered. I was like, oh, that's a good thing to remember for later. you know, 2 to 3 years later, when it was my time to apply, I was like, you know what, let me do these 8 essays. I hate writing the essays, but I was like, this is important. If Shot in the Dark hopefully comes together, ask that same English teacher to write my letter of recommendation. And then thankfully I was able to get it. But again, I relied heavily on sort of my guidance counselor reached out to the previous recipient from my school about how to kind of navigate that. But yeah, just went for it really.
And then how did you decided to found MDC? Is it a nonprofit or is it a social startup?
Yeah, so it's a nonprofit organization. It's a registered nonprofit organization that is socially social. It's a social venture. How I like to describe it. With the work that we're doing, we're a very socially minded organization. trying to work towards improving mortality surveillance, basically bringing that 50% or 90% to zero in an ideal world. Yeah.
But do you make money off that, or is everything free?
Yeah, so the way that we operate is sort of like two revenue streams, so to speak. One is the funding and grants. That's a big part of how these projects get funded in sort of the global health, public health world. But also, we've been trying to get a little bit, I would say, creative with how we're able to fund some of these projects. First of all, by reaching out to more well-resourced international organizations that may have offices in some of the regions we're trying to work in, to be able to fund some of the work. Sometimes we partner with these organizations and tell them, hey, if you have a current partnership with another international organizations, let's say the WHO or the UN, maybe you can add this on top of it as an additional project as well. But yeah, essentially the funds that we get are mainly from those two streams.
Fascinating. And
Yeah.
okay, the outcome of not counting the deaths is that you don't
Mhm.
get the data to prevent further deaths from happening, right?
You nailed it. Exactly. If we don't know a particular disease or illness is really burdensome to a particular community, then we wouldn't be able to allocate the proper resources to addressing that. So, some of the basic examples that I use is, if you realize, let's say, COVID or malaria are one of the biggest burdens in your community, they're the leading cause of death, then probably, as a decision maker there, you want to implement a public health initiative to introduce more vaccines, to look at different practices for social distancing, so on and so forth. If we found that actually, car accidents are a big issue, then maybe you want to invest in sort of the infrastructure of the roads. Or if you find that, for example, stroke is one of the biggest causes of death, and we know that part of the treatment algorithm for having a stroke is sort of your door-to-door time, the door from your house to the door to the hospital in order to get the medication you need to break that clot. Then maybe as the decision maker and you're thinking about building a new clinic, you want to put it where there is the most amount of cases of stroke, and we were able to look at that.
Yeah, tell me about death causes, for example, in CAR. What is happening here?
Yeah, so there's a lot of I would say there's a lot of these issues of the lack of registration. So like I said before, there's this issue of um, first of all, there's a lot of remote areas in some of the low and middle income countries where there's very little registration of these causes of death, and it doesn't become an issue sort of for the country until it starts to spill over into the capital city. So we actually saw it one of the a couple months ago, I would say, I think in East Equatorial Guinea, they had this outbreak of malaria, but it's been going on for quite some time, but nobody really noticed it until it started spilling over in the capital city. We actually have sort of some projects right now in northwest Syria as well as in Somalia, where we're looking at some of these causes of death in traditionally places where the government has not gone in at all and collected this information. So that's kind of just to give you a sense of the scope of the issue and how burdensome it has been to some of these governments.
And in CAR, it's a war, right? Like I think what's happening there, Central
Hmm.
African Republic. What about
Correct. Yeah.
what's happening in Gaza? What have you found out?
Yeah, so we haven't been working in Gaza. So I think one important distinction is that for the work that we do, at least up until this point, we work in sort of areas that have historically experienced humanitarian crises but are quite stable. So I would say again, Northwest Syria and Somalia, they're not actively, at least in the areas that we work, they're not actively undergoing conflict. And that's kind of a two-part reason, right? One is we wouldn't be able to manage that even with our partners during a conflict zone and trying to collect that information, at least not right now. We have some solutions to work around that. But also the other thing is we really try to come in and provide this gap of knowledge about what the causes of death are during these active crisis settings. um, you could really chalk up most of the deaths to war. Now there are these ancillary causes of death as because of war, such as lack of access to water, to food, to medications, which are all very important, but the primary leading overwhelming cause of death is due to the war effort. So that's kind of in our work and understanding of what's going on in Gaza, that's the main cause of the issue. And there's not much more we can sort of provide in sort of the understanding of what's causing the deaths. People can see and understand what's happening there.
Yeah, because I mean, Gaza and Israel, it's not really about like counting deaths. We know that like in Gaza,
Mm-hmm.
it's probably, I
Mm-hmm.
don't know, 10x or 10 to 30x more elevated. A death is a death. But why are the stats not counted? Like, is
Mm-hmm.
it that people don't want to count them? Is it propaganda?
Mm-hmm.
Is it the lack of a tool, or is just
Yeah,
like the fog of war? Like, how can we count that and
of
know what
course.
happened?
Yeah, that's an excellent question. So I'll answer it in kind of two parts. One is overall globally in the non active humanitarian crisis settings, the non-active conflict areas, which is lack of infrastructure. Because again, in order to count the death, you need to have the physicians and the hospitals around. So we're talking about distance of how many hospitals, how many doctors do you have to a certain population? Can the doctors actually keep up with the amount of deaths, right? In order to actually sit down and write the causes of death. So sort of the personnel number, the public health infrastructure, um, financial cost. Again, the family whose father just passed away and they barely make any money. They're like, look, they passed away. I don't know if we want to really go through the effort of reaching out and driving all the way, 20, 30 kilometers or miles to the nearby hospital to get a second opinion or an opinion about what the cause of death is. Another huge one that we've seen is a cultural and religious barriers. So part of the understanding of what these causes of death are include actual autopsies. Some of them, some causes of death you can know with a physical exam or lab reports or blood work. But there are other causes of death where you frankly need to do an autopsy and get a specimen from the body. And people are like, look, that's desecrating the body. We're not going to do that. And so that also is a huge barrier to collection of the information. Another big one is people just don't know it's an issue. People just really don't know that there is this lack of registration because again, for most people, what a registration is literally a piece of paper that says the person's name and then let's say cardiopulmonary arrest. The heart and the lungs have stopped working. Well, that's not very informative because in every death, the heart and the lungs stop working. And so there's not this added level of investigation that sometimes we take for granted in the West of really trying to understand what the leading cause of death. Has it been diabetes? Has it been an infectious disease? Has it been, a chronic disease, cancer, so on and so forth? So there's really a lot of these issues, and of course, goes without saying, funding in order to put together projects like these to collect that information. And people are like, look, we will worry about it once it becomes an issue. Unfortunately, that's a lot of the mindset. We're not going to do this active surveillance, so to speak, and go out into these communities and collect this information. If something happens and starts spilling over, like I said before, in sort of the more densely populated areas, the capital cities and the major cities, then we'll allocate the resources and deploy the personnel needed to address the issue. But until then, it's not really a big factor for people until it does become one. Now, that's kind of the part of like globally and some general issues. Now, in areas of conflict, you take all of that plus the fact that it's very difficult for those who the community health workers and the physicians who are actually conducting these interviews and collecting that information to do their job. It's not safe for them. There's a lot of roadblocks to go into. I mean, uh, there's been a lot of news coming out of Doctors Without Borders about their efforts and how it's been hindered. Usually in a lot of these conflicts, it's sort of like I would say it's an unwritten rule that when humanitarian organizations come in to provide medication or to provide access to care, essentially, then they're sort of a neutral party. They're not to be confronted or to be put under any danger and let them do their work. That has not been the case in Gaza, quite frankly, and so that's an additional barrier. People are not actually getting in contact with the communities that can tell them what the issues are to again allocate the resources that they need. So there's a lot of different barriers to getting this information.
And I just checked the stats. It's 30x more deaths on the
Mhm.
Gazan side. That is striking. I didn't
And that's
check
what's
that.
reported. Yeah.
Yeah, and I had to check it from ChatGPT, like via
Mm,
Google. What do you think of quality information and where people should get their data nowadays?
yeah, that's a brilliant question. I think this is quite depending on who you talk to, it's quite a contentious topic because depending on, first of all, you need to be very clear about what you're looking for. Unfortunately, if you don't have sort of the background in understanding what these numbers are and you just read a headline, 10% of whatever are dying, there's a lot of nuance into how that information is collected, how it's being reported. In the world of public health and mortality surveillance, there are many different ways of reporting deaths. Do you report it per capita, meaning like per individual? Do you report it on a population size? Do you report it as a rate? Do you report it as a prevalence? There are many different ways that you can look at it. So first of all, I definitely recommend being very clear about what information you're looking for. Secondly, I think going to credible sources such as the WHO, the UN. One resource I really recommend for a lot of this kind of data work is the Institute for Health Metrics and Evaluation, IHME. They're essentially a data science group out of the University of Washington in the United States that has been doing a lot of his work in collecting sort of global burden of disease. Collecting information on where are there the biggest amounts of malaria or diabetes or Alzheimer's, so on and so forth. So they're quite a credible source of information. I would say those are great places to start. And then if you want more specific information, you can go to sort of country-specific Ministry of Health websites. They usually have like a statistics department that collects this information. But again, there's also a lot of this information is lagging, right? You might say the most recent data from like 2019 or 2018. So it depends on what you're looking for and how current you need it to be.
Yeah, ChatGPT, I believe they scraped PubMed. So
Mm-hmm.
that's really cool. But on the other side, they scraped Reddit. I mean, probably the one of the worst place to get your
Yeah,
information.
100%. It's definitely,
What
yeah.
do you think about Wikipedia?
Wikipedia is a great source to get some background information, but it's nothing to ever rely on because it's open source. People can edit it. Anybody can say what they really want, put whatever numbers that are there. I think it's okay in two senses. One, if you're beginning your research, just to read some of the background information, but more some of the more finer details, you need to go somewhere else. Or if you've done quite a bit of research, you can go to it knowing what you know and you have a foundation in the information you're looking for to take a look at it. But truthfully, there's just so much there's so much better, more accurate information out there that it shouldn't be anybody's like top top source.
Right. I'm gonna find the name of that AI that was quoting scientific resources. I lost the name, but I was
Hmm.
using that for a while. Um, Now, what are the unexpected sources of that? I've read on your website hippopotamus and vending machines and stuff like
Mm,
that. Like tell us, and coconut falling. I thought about that because there's palm trees here in Oaxaca,
yeah.
Mexico. So, what are unexpected sources of that?
Yeah, so that was, if you look at most of our content, it's pretty heavy, obviously because of the work that we do. So it was kind of sort of a bit of a lighthearted topic, but look, it still falls within the realm of some of the causes that are out there. People, that's actually a good point to talk about a bit is that some of the more extreme causes of death get a lot of spotlight. Maybe like a plane crash or a ship sinking, but people don't, they don't really put into context with regards to, well, how often does that happen? How many people are actually suffering from something like this? And on the other hand, sort of the other cause of death, like we talked, like coconuts falling, furniture at home falling on small children, like these are real things that actually are causing more of a burden of number of deaths than some of the more headline news. We talk about hippos you were talking about, but animals in general. It's some animals may seem docile and they may seem you know they're vegetarian, but it doesn't mean that they're still not dangerous. So they're sort of these things that people need to still keep an eye out for.
What are your goals this year? What do you want to focus your time on?
Yeah, certainly. So we just wrapped up a project in Somalia. One of our biggest kind of goals whenever we end up doing a project somewhere is to try to expand it. So when we go into a particular region, we do really what's called a pilot project, where it's more proof of concept. We try to collect information from one particular town. And then what we're hoping to do now is to be able to garner some more funding to expand it in Somalia to some more neighboring areas and really make this sort of a bigger project. But we're also trying to expand to one or two more countries for before the end of the calendar year, in order to expand sort of our work, particularly hopefully in Sudan and India as well.
Interesting. And how can you scale your company? That do you feel that you can get as most data as possible? And would AI have a role to play in the data collection, filtering, and
Mhm.
analysis?
Yeah, certainly. So I think we rely. So part of the work that we do, just so for some context, is that when we partner with our partners, the NGOs on the ground, let's say, they end up training with our help community health workers who go out and interview the families of the deceased. So again, they ask the mother or the father who lost their child about certain questions. Did your loved one have diarrhea, fevers, chest pain, so on and so forth? And we collect that data and we actually analyze it using our algorithms to come up with the likely causes of death. So we look at 54 causes of death that we are able to, put our stamp of approval upon and say we can with certainty say that these are what have caused the death with some leeway, but more than 90% of the time it's correct. And so we actually think that the use of sort of machine learning and AI is crucial for the work that we're doing because it helps to provide sort of this trio that is almost usually missing and causes a big barrier to global health work, which is money, promptness, and accuracy for projects. So money, it lowers the overall the overhead because in a lot of these areas the only other way to get this information, these causes of death, is to have doctors on the ground spending their time in order to collect this information. So we mitigate all of that by the use of our algorithms. It gets done in a couple minutes. The other thing, it's prompt. You're not collecting all this information and a lot of paperwork, sending it over to some hospital facility for a doctor to sit down. How long will they take to actually sift through all the information? Again, with the use of our algorithms, it gets done in a couple minutes. So they get the information much quicker. They get the information that is much cheaper than they would otherwise. Plus, the information is accurate. We've conducted sort of these the studies on the algorithm, and we found that it is as accurate, if not more so, than what we call physician coding of these surveys and these data. Because again, some of the areas that we're working in, there are physicians who don't have the expertise or the skills necessary to provide these accurate causes of death. But with AI, you train it on data. Sort of really, when we train it, it's all across the world, and it's able to simulate a very experienced physician, at least for some of these causes of death. Again, there is no substitute, we always say, for an actual doctor to go through this information, but in a lot of areas they don't have that option. So we're able to sort of address all of 3 points. And more specifically, when you're talking about scalability, yeah, this is definitely something that is crucial to scaling the work. I mean, we're only limited. I say only, it's a big issue, but we're limited by the funding of what we're able to do. But we're not limited by the amount of information that we can analyze and provide. So I think this is something that's crucial for especially social ventures that really are trying to scale.
Interesting. Thank you so
Mhm.
much, Ahmed. I found
Of
the
course.
language modeled, or at least the chat GPT like front end. It's called perplexity.ai, the one that
Okay.
cites the scientific sources. Where can people find out more about you?
Yeah, certainly. Well, my LinkedIn, people can definitely find me there. My website, people can go on to MakeDeathsCount.org, and feel free to reach out to me, Ahmad.Saleh at MakeDeathsCount.org. First name, last name, MDC. Yeah.